Hello, good afternoon, everyone. Thank you so much for having me here today. I'm excited to share a topic that's close to my heart, not because of experiences that I've had back in residency. So today I'll be discussing must-know post-operative concerns in managing cataracts in the pediatric population. So my main objective here is to emphasize that the post-op period really matters in assuring good visual outcomes in these cases because surgery alone will have limited value if your post-operative follow-up is lacking. And of course, the management of these cases does not just end with surgery alone. Rather, visual rehabilitation actually extends well into the child's future. So it's important to monitor these children in the long run. Okay. So when we talk about the post-op period, there are three things that we have to take into consideration. These include post-operative care, complications, as well as visual rehabilitation. So beginning with post-op care, this essentially pertains to our medications. So the ones highlighted in green are what we routinely administer for our patients post-op. Those in orange are what other sources or reference would suggest, but we don't routinely make use of NSAIDs or anesthetics post-op. So just like in adults, we also administer corticosteroids post-operatively to reduce inflammation. The routes could either be subconjunctivally or topically. We give subconjunctival dexamethasone single dose intra-op for complex or difficult surgical cases. But for all patients, we administer topical corticosteroids, spread forte specifically, and over a course of 4 to 12 weeks, and we taper that accordingly. We also administer antibiotics, of course, for post-operative infection prevention. We routinely give a dose of intracameral antibiotics intra-op, and we do give topical antibiotics Q4 for 1 to 2 weeks. Oftentimes, we just advise our parents not to just consume the bottle. Now, in terms of pediatric lensectomy or cataract management, unlike in adults, we actually make use of cycloplegics, primarily to reduce pain, inflammation, and prevent synechiae. It's topically administered. However, there is no uniformity in the post-op use of cycloplegia in pediatric cataract surgery. It's case to case. It's usually clinically indicated, especially if we note that patients will present with unresponsive pupils or pupillary membrane or significant inflammation during the post-op follow-up. Now, an important thing to note here is, especially if we use atropine, no, this can actually predispose the patient to developing IOL pupillary capture, no, especially if the IOL is implanted in the sulcus. Cycloplegics are given over a course of 1 to 4 weeks. Again, I have to emphasize that this is basically given per clinical judgment. Okay, now we move on to the complications. So, as I mentioned earlier, there are various post-operative complications that can occur despite having successful cataract surgery in children. And so it's important to diagnose this early and treat early in order to prevent further visual complications and eventually visual loss. So there are multiple complications that can occur, with endophthalmitis, of course, being the worst complication. Okay, so I'll just go through some complications and their associated managements really quickly. IOL capture is actually an early complication that can be the main reason for the lack of visual improvement post-op. And this capture can actually also cause pupil distortion and patient discomfort. So how do we manage? It's primarily preventive, no? We have to make sure that we properly implant the IOL intraoperatively so that we can avoid this, because we don't want to subject our patients to repeated surgeries, because remember, in managing pediatric patients, our surgeries are performed under general anesthesia. Okay, so another complication would be post-operative uveitis or a severe fibrinous reaction, because children have a very harsh and vigorous inflammatory response as they heal. So you have to promptly diagnose and start them on aggressive anti-inflammatory medication. Okay. PCO or posterior capsular opacity, it's a frequent and very common post-operative complication. And it's very significant for children because PCOs, unlike in adults, can actually obscure your visual axis and cause amblyopia. Now, the development or the occurrence of PCO actually varies, no? So according to Batur et al., he noted that PCOs would develop as early as 1 week to as late as 71 months post-op in patients aged 4 to 12 years old. And according to Wilson, he noted that PCOs developed at 18 to 24 months post-op in patients between 5 to 6 years old. So essentially, just like in adults, management of PCO would be YAG-CAP. But how can you YAG-CAP a 2-year-old patient, right? Or toddlers or infants? So for that case, we actually bypass the YAG-CAP by performing a posterior capsulorhexis and anterior vitrectomy for our younger patients intraoperatively. And by doing so, we are able to lower the incidence of PCO development. So it's part of the surgery. You have to do a posterior. So apart from doing an anterior capsulotomy, you have to do a posterior capsulotomy and an anterior vitrectomy. Okay. Another complication would be amblyopia. This is a principal cause of vision loss in unilateral cataract, especially, right? Because there's deprivation amblyopia, which is actually the most refractory to treatment. So, how to manage amblyopia? We occlude the better eye or the sound eye. However, as of this writing, there is no evidence based guidelines. Some would opt for a more intensive management, no, starting the patient with 6 to 8 hours or 8 to 10 hours of patching per day. Others would promote a more progressive approach at 1 hour of patching per day per month of age and then gradually increasing that accordingly. According to the infant aphakia treatment study, they suggested 1 hour a day per month until the child is 8 months of age. Then, of course, increasing that to 50% of waking hours. Okay, although we can discuss amblyopia in depth at a different time. So important to note that the maintenance therapy lasts usually about 1 to 4 hours a day. When do we stop patching? We stop when the patient's visual acuity eventually plateaus and does not improve. And you may also opt to restart patching therapy when you note that visual acuity worsens again. Another complication would be secondary glaucoma. And this can be attributed to post-op inflammation or even structural and anatomical destruction due to the surgery. So we have to make sure to just monitor patient's IOP post-op. And if ever pressures are elevated, we can start on medical management. And for uncontrolled cases, we refer to glaucoma for surgical management. Okay. Another complication, though rarely seen in children, would be post-op cystoid macular edema. And it's also the possible mechanism, of course, of visual impairment post-operatively. And just like in adults, we can start them on topical NSAIDs. Now, worst case scenario, of course, would be post-operative endophthalmitis. It's the most hazardous and feared complication. Just like in adults, it can occur both either in early or late phases post-op. And though it's very uncommon, it can occur. Okay, so how to manage prevention is key. You have to do proper pre-op antisepsis with povidone iodine. We also promote the use of intracameral antibiotics. Very important to monitor your patients so that you can promptly diagnose and treat. So when dealing with endophthalmitis in kids, we have to remember that it's a multidisciplinary team effort. No, you refer your patients to retina service, to pediatrics, to anesthesia also. Why? Because retina would help you with your intravitreal antibiotics while waiting for your patient to be cleared for GA because the patient has to undergo vitrectomy right away. Then, of course, PDOPHTA will help with the visual rehabilitation post-op. Okay, so there are lifelong risks. Okay, and lifelong risks include retinal detachment, which are, of course, increased in children after cataract surgery. And this complication actually is more noted in myopic children and among children that have had multiple surgeries. There is also a lifelong risk of glaucoma that develops after cataract surgery. And so, again, as mentioned earlier, it's important to monitor IOP. Okay, now we move on to the third part of the report, which is visual rehabilitation. And it's in this part where I'll be discussing a bit more extensively. Okay, so remember, managing childhood cataract begins at the initial contact with the family and extends far into the child's future. So you have to manage these children and monitor them, over the long run. Okay, and so with that said, you have to thoroughly discuss your treatment options with the parents. And we never promise 2020 visual outcome, right? We always try to aim for best corrected visual acuity. And we noted that patients, older children with bilateral cataracts actually have the best prognosis in comparison to younger patients with unilateral cataracts that have higher risks of amblyopia. So here's an article, and I'll just focus on the key points of the article: updates on management of pediatric cataract. So this states that post-op visual rehabilitation is a challenge. That's true. It's essential to initiate optical restoration as soon as possible. Why? It's because we want to reduce the incidence of amblyopia, strabismus, and poor fusion. So visual rehabilitation or recovery primarily includes IOL implantation, use of glasses, or even contact lenses. And for patients with bilateral aphakia, we make use of aphakic glasses. Okay. Now, what about contact lenses? Contact lenses are actually optically superior to spectacles. Why? Because there is a significant reduction in anisoconia in comparison to the use of aphakic glasses, right? And however, despite being optically superior, it's not as feasible to use contact lenses in the long run because it's expensive and you can't ensure proper contact lens care in kids, and sometimes even parents are hesitant to make use of contact lenses with their children, and so we promote the use of spectacles post-op. Children undergoing cataract surgery must be followed up lifelong for proper management of early and late postoperative complications. And so again, main parts of post-op visual rehabilitation, similar to what I mentioned earlier, is essentially refractive correction. You have to treat amblyopia, and we start bifocal correction for children in school age. Okay, so most eye growth occurs during the first 2 years of life. We note myopic changes in eyes undergoing IOL implantation. So essentially, the younger the child is at the time of IOL implantation, there's actually a greater myopic shift. So as much as possible, you want to delay IOL implantation to when the child is 2 years old and above. And then if you compare patients with pseudophakic eyes versus phakic eyes, myopic change is actually larger in pseudophakic eyes. Okay. Amblyopic eyes also showed more myopic change compared to the fellow eye because there's an elongation effect that occurs. Okay, so another article, key points of this article show that with unilateral cataracts, 50% of eyes with unilateral infantile cataract will develop a vision of just better than 2200, so it's relatively poor. For these cases, we promote either contact lens or IOL for the best result with a chance for binocularity. And it's important to start the treatment of amblyopia by occluding the better eye as soon as possible post-op. For bilateral cataracts, visual rehabilitation is more flexible. We can use contact lenses, IOLs, and aphakic glasses. And in these cases, we expect better visual outcomes, unless, of course, other complications occur. Okay. Use of an IOL is most commonly accepted and performed for either unilateral or bilateral cataract after 1 year of age. Because prior to 1 year, so when they're younger, you actually need to subject these patients to more surgical procedures in order to manage these cases. And as much as possible, as mentioned earlier, we want to reduce the exposure of the child to general anesthesia. Okay, and again, amblyopia therapy for unilateral cataract needs to be continuous from the time of surgery until at least 8 years of age. Although, again, this The timeline varies. Some authors would say that you just have to monitor visual acuity, and if the visual acuity plateaus, then you may stop. And then if it worsens again, you may restart. So monitoring is key. Okay, another article. One more. Key points lang. Okay, so cataract surgery improves the visual acuity but leads to loss of accommodation because you remove the crystalline lens. And because of that, you have to start bifocal glasses, especially for school aged children, to help them with accommodation and to optimize distance in near vision. Okay? Um, According to Lambert et al., yeah, okay. So in terms of the long-term visual outcomes for children with dense bilateral congenital cataracts, if you delay the cataract surgery to 10 weeks or later, then there is an increased chance of poor visual outcome. And if you do the surgery before 6 to 8 weeks of age, there is better or good post-operative visual acuity in most healthy children with dense bilateral cataracts. So what is the optimal age for cataract surgery? For unilateral cases, it's between 4 and 6 weeks of age, and for bilateral congenital cases, it's by 8 weeks of age. So visual rehabilitation involves these four entities, right? And this is just a summary of what I mentioned earlier regarding the pros and cons of either aphakic glasses, contact lenses, and IOLs. So it's a case-to-case basis. You have to know when to use either of these three to, again, give your patient the best corrected visual acuity. So during fellowship, we encountered several problems when dealing with pediatric cataract cases. And so one of which included treatment delays because there was a lack of awareness and urgency, especially among the parents, and apart from that, financial difficulties as well, and in securing both pediatric and anesthesia clearance issues. Now, unfortunately, despite trying to promote awareness among patients and having good surgeries, some patients are lost to follow up, because some of them were just living very far from the hospital, and apart from financial difficulties, again, there's a still a lack of awareness to the necessity of long-term follow-up care. So again, especially when dealing with, let's say, our HSP or charity patients, you have to really emphasize the importance of not just surgery, but long term follow up care with the parents to ensure that the child gets the best outcomes. Okay, so I'll just share with you a case we had, and this is just a post op course, no? We had a 5-year-old female with bilateral congenital cataract. And for this case, we did a bilateral lensectomy, posterior capsulotomy, anterior vitrectomy with IOL implantation under general anesthesia. So we followed up this patient at day 1 post-op. And with kids, you can't expect them to cooperate. This patient was very fussy day 1 post-op. Patient was reportedly in pain and did not want to open her eyes. So we just tried to do a quick examination, propped open the eye, tried to see the cornea. We noted that the conj was hyperemic because she was crying at this time. And unfortunately, we could not check for ROR. So our plan at day 1 was to continue post-op levofloxacin and predforte Q1 for both eyes. Of course, we have to make sure to continue the use of protective goggles so that we can prevent scratching. And follow up as advised, we told the patient to come over at day 3 post op. At this time, we still could not examine the patient properly. Patient could hardly open her eyes. However, she was less irritable than day 1. We did a quick external examination, noted clear cornea, a formed AC with a bubble in the anterior chamber. She had constricted pupils and ROR, OU, which are good signs. We advised to continue levoflox and predforte Q1. And at day 3, we started cycloplegics. We gave tropicamide plus phenylephrine, QID-OU. Now, usually we give cyclopentolate. However, I think cyclopentolate was unavailable at this time, so we had opted for this instead. Again, continue protective goggles and follow up as advised. Day 10, patient finally had spontaneous eye opening and she was comfortable. Vision at this time was fixed as follows from pre-op of blinks to light. Also, I have to note here pala that this patient had some neurodevelopmental delays. So it's actually even more difficult to examine the patient and to actually um, get a more concrete visual acuity from this 5-year-old. Okay, so external eye exam was unremarkable. At this time, we then decreased levofloxacin and predforte. We tapered accordingly and continued the cycloplegics. Then we had her follow up at day 17 post op. VA was still stable at fixes and follows. External eye exam was unremarkable. And we tried to do an initial refraction, and we noted that she had plus 250 sphere on the right and plus 350 sphere on the left. On this day, we decided to consume levoflox and predforte. Then we decided to discontinue natacycloplegia. And then we wanted to repeat refraction after 2 weeks. So our target was to do a final refraction at 4 weeks post-op. And then since she's 5 years old, now we wanted to incorporate +2 ads into the sphere instead of giving her bifocals. Number one, she's only 5, she's not yet school age. Number two, she had neurodevelopmental delay. So how can we expect her to know how to use bifocals? So we just incorporated the ads into her sphere. Okay, then okay, finally 1 month post-op nga. So again, VA was status quo, external eye exam unremarkable. We did a final refraction and we gave the spectacles. Notice it's, yeah, so and with the final refraction, we actually already added the +2 sphere. That's why we sent her home with +4 sphere combined with -1 cylinder at 180. Okay, so our follow-up course ends here, but technically you should still see the patient after 1 month of eyeglass use and then monitor again accordingly. It doesn't end at 1 month post-op because the child is still growing up, and as the child grows, refraction changes. So you have to keep refracting essentially. So in summary, visual outcomes following congenital cataract surgery have significantly improved because we have a better understanding of the development and reversal of amblyopia. We also have better understanding on the timing of cataract removal, and there are improved surgical techniques. Post-operative care is essential. I cannot overemphasize that. Primary IOL implantation is, of course, preferred in children above 2 years. For those under 2 years, we leave them a phakic and we give them phakic glasses. Okay. So, as mentioned also earlier, unilateral congenital cataracts actually present a poorer prognosis than bilateral congenital cataracts. And what else? Okay, options to restore good vision after cataract surgery, whether this patient has unilateral or bilateral cataracts, would include deciding to use either contact lenses, IOLs, or glasses. And frequent fine tuning of the refractive error with glasses is very important and much needed. So these are my references, and thank you so much for your kind attention.
Thank you, Bea, for the great lecture. Do you have any questions?
May tips ka ba for yung mga residents na wala masyadong experience sa mga batang cataracts? Like we have, I know it's magkaiba talaga sila ng ano, pero meron ba kayong may or tips na para mas mapadali for us? Like, kung nakita ko ng children na cataract, like, prepare na ng moment or something to keep in mind while we're doing it.
So, unlike adults, diba, parang diagnose cataract with biometry image ready done. We have IOL. For kids, it's very different because it's management is not just is not just all intra-op. There has to be a very good pre-op assessment, intra-op management, and post-op management. Pre-op, you can't just do an IO. You have to do a B scan, assess the status of the retina, assess the status of the vitreous chamber, Because what if, you perform cataract surgery because there's another pathology pala behind the eye? Problem then. Okay. Um, in terms of, you have to also decide whether or not you insert IOL, because that will also affect your surgical management. Again, is the child 2 years old and above? Kung 2 years old and above, you plan for IOL implantation. With IOL implantation naman, you can't just subject the child to regular biometry. Lalo na if this is just a 2-year-old, you can't, diba? You have to do contact, after immersion, right? Immersion scan. And then from there, you have to decide your target post-op refraction. Once you decide your target post-op refraction, you compare that to the IOLs that you got through the biometry. Okay. Pero kung younger than 2 years old yan, leave a faking. You're done. Okay, so once you've decided whether or not to use IOL, you plan surgically. Surgically naman, unlike in adults, you don't need to use phaco power. You just use your IA because you can just aspirate that. It's really soft. But another challenge would be your capsulorhexis. The capsules in pediatric eyes is very gummy, but we also noted that it's varied. There are some cases na very, very parang makuna and it rips right away. So very delicate talaga yung the capsulotomy procedure. If, let's say, for example, you have difficulty with the capsulotomy, you can actually use your anterior vitrector to do a vitrectorexis of the anterior capsule. So you'll just eat the capsule like that. You don't have to use your utrata and peel it off. You can go straight. And with a vitrector, you can go straight to do a lensectomy and then a posterior capsulotomy. That's one option. If you're senile to using your anterior vitrector. If not, you can go the usual route, use your utrata, use your INA for lensectomy removal. Then you get your utrata again and do your posterior capsulotomy. Or you may use the anterior vitrector now. It's so much easier with the anterior vitrector. And then go straight into do your the capsulotomy, then anterior vitrectomy. Another thing is you always have to make sure to suture your incision sites. Whether that's main port pa or side port, it has to be sutured. And what we do also to maintain the chamber, we inject air. Pwede rin. So that at least post-op, when you see your patient and check, that's going to be a fussy patient, irritable. As long as you see the bubble, you're good, meaning your chamber did not collapse, may space pa, and you're good. and then post-op management, it's a different ballgame. So a helpful tip: watch videos. Watch videos online. Madami.
Do we have any other questions? From Dr. Valero.
Thanks so much, Bea. Question lang. Do you routinely do anterior vitrectomy na for all pediatric cataracts, or do you reserve it for certain age or certain indications? That's one. Two, do you use triamcinolone when you do anterior vitrectomy? And three, in terms of post-op, how often do you refract them after you've done your first, stable refraction? How often do you make them come back to check the refraction?
Hi, Doc. We do, it's case to case. So not all patients, we don't do anterior vitrectomy, posterior capsulotomy for all patients. We usually reserve this for the younger patients that we know won't be able to tolerate a YAG cap. So toddlers, infants, yan, we routinely do anterior vitrectomy and posterior capsulotomy. For older patients, teenagers, and more cooperative patients, we can bypass that and we just prime the patient that once we note the development of PCO, we have to do YAG cap. So the next one, do we use triamcinolone? No, doc. Based on our experience, we don't use triamcinolone, so we just try to do a very thorough anterior vitrectomy, extending, of course, also to the incision site. So we make sure that there are no vitreous wicks. And then in terms of refraction, so the earliest refraction we did or that we've done so far is at 2 weeks post-op, but then we give a more committed refraction at 4 weeks post-op. Then we ask our patient to follow up after 1 month of spectacle wear. Then it's every 4 months, 6 months, and then yearly from there.
Okay.
So again, we also monitor and see if the glasses are adequate for the patient. And whenever we do a refraction, it's usually cycloplegic, so cyclopentolate, not just
So your IOL is usually in the bag, correct?
For yes,
And
doc,
what
in the
kind
bag.
of IOL do you usually use?
It varies then, doc. So for younger patients where we already plan to do an anterior vitrectomy and capsulotomy, we target to use 3-piece IOL. For older patients, we can use single piece. However, some consultants would they suggest to use 3-piece IOLs regardless, whether or not you're going to do anterior vitrectomy or not. Some prefer to just use 3-piece straight away because it's more stable,
Yeah.
but it's
Well,
basically
any because when I used to do pediatric cataracts, no, I would routinely do a posterior capsulorhexis, but not always an anterior vitrectomy. No, there was an argument before kasi na parang as long as you do the posterior capsulorhexis, you're hoping that the epithelial cells do not migrate over the anterior hyaloid, no? Yeah, and then there's another school of thought that kainin mo talaga yung vitreous so that you prevent that, no? I think most na ba ngayon is leaning towards anterior vitrectomy na. Yeah,
yes,
okay.
doc. Yes,
Okay.
doc.
All right, thank you.
Thank you, doc.
Dr. Mitzi.
Hi, Bea. Thank you for the lecture. No, it just reminded me so much of our time with Dr. Tablante because this was one of his pet projects was the pediatric congenital cataracts. I'm just curious. No, I noticed your post on the case that you presented. The post-op refraction was a +2 hyperopia. Is that an intended outcome, or and also how do you decide on what power? Because before, what we used to do with Dr. Tablante, there was a lot of second guessing on what power of implant to put. So now I'm wondering if there is a good formula already, given that they do have axial myopia.
Hi, doc. Okay. The post-op
Yes.
refraction of +2, that was our target. We make use of the rule of 7. So that's 7 minus the age of the patient in years. So in that case, the patient was 5 years old. So 7 minus 2, 7 minus 5, 2. So that was the target post-op refraction. We input that to, we have a pediatric calculator. It's a PediaCalc software wherein you input that information and then it will generate information about the patient's targeted refraction at 20 years of age. So you extrapolate that and then you compare and see, which particular power would give the best visual acuity with the least risk for amblyopia at present and in 20 years of age. So we input that information and we got our target of +2, and we compared that to the biometry and just found which particular IOL generated that particular refraction post-op.
Thank you. At least now there's a formula.
Yes, doc.
Any other questions? Oli.
Because I don't know the answer.
Okay.
You did mention in your presentation earlier
Yeah.
that post-operatively, the children lose accommodation.
Yeah.
Has there ever anything in the literature or by experience though that accommodative IOLs or EDOF or multifocals have been used in children? Or what does it say?
It's difficult to compute. It's difficult na to compute just monofocal IOL for these children because again, they're growing, their refraction changes as they age. And so if you implant an accommodative IOL or an EDO, it's just gonna mess things up a bit more, diba? So, you do a bilateral lensectomy, you remove the crystalline lens, there's no more accommodation, we just give them bifocals to compensate for that. And then maybe when they're older, you can probably inserting accommodative IOLs, but in my experience, never even considered.
Thank you.
Like I said, you just want to make them mature first, but then we're dealing with a period where everything is still so immature and very uncertain and very unstable. So you want to give the simplest, most effective management that will give them BCVA for that particular age. At the same time, preventing amblyopia, preventing strabismus, preventing loss of fusion and stereopsis, diba? So go BCVA.
Thank you, Doc.
Don't make things complicated for you.
We have another question from Dr. Ina.
Thank you very much for the exercise. So there's always a risk for amblyopia for these patients, right?
Yes, Doc.
So I think my question is related to what Dr. Valero said. So
Yes, Doc.
the onset of your, kasi you always have to check with the EOR, diba?
I
So
don't know.
parang more or less, no, easy question. So more or less parang you do it after 2 weeks.
Yes, Doc. That's the earliest we've done so far.
But when do you decide to give glasses?
4 weeks.
4 weeks.
4 weeks. Based on what our consultants would advocate that the East have, Doc. So at 4 weeks, we do a more committed refraction. Send that prescription patient. Once it's come back, we do 1 month of eyeglass wear. We see if the child tolerates it. And we see if it's neutralized then post-op.
That's the latest, Bea, that you,
Yes.
4 weeks, paglagpas,
Well, what do you mean latest?
pag more than 4 weeks. 4 weeks the latest that we can give the glasses.
Case to
Case
case, but parang standard doc,
Standard.
at 4 weeks, we give a more committed refraction na. Because again, target doc talaga is BCVA. So the more we prolong giving them spectacle correction, there's an increased risk for amblyopia. So you want to be able to make sure to give them the refraction once the eye is as stable as possible at the earliest time possible. And so we found it's 4 weeks.
Si Dr. Valero.
Kasi diba, I saw yesterday also for amblyopia. So when do you start the patch?
As early as day 1 post-op, based on the articles we've read.
Even
Right.
without the glasses, right?
Yes, no. Like, let's say, for example, for unilateral cataracts especially, we can occlude na the better eye. But then, many times, kasi kids really are so difficult. And they don't tolerate, so you have to try to do it progressively na lang.
Dr. Valero.
Two questions pala. How do you do your K readings? What's the easiest? Is there an easy way to do your K readings when you do your biometry? Do you get it? I don't know how you got it. And 2, you said you put in a suture, diba? What kind of suture do you put in, and do you have to take it out at any point?
Yes, Doc. Usually for younger kids, we make them do immersion scan na lang. And for
Pero
older
ang
kids,
kera mo, paano kung immersion na scan, you get an eggshell length, how do you get your kera? Based on ano?
it's
Refraction na lang? Paano?
from the immersion scan.
Meron din bang ano doon?
Yes, Doc.
Okay. Sige. And then yung suture na nilalagay mo?
It depends. Sometimes, Doc, nylon 10-0.
Okay.
Kung nylon 10-0 after move. If Prolene, it's
Okay.
absorbable.
Okay.
So we prefer Prolene.
Okay. Sige. Thank you.
No, Prolene. Yeah, Prolene. Prolene.
Do we have any other questions pa? Bea, in post-operative cataract surgery, in yung antibiotics na binibigay mo, what do you prefer? Combination or magkahiwalay na bread and antibiotic?
Separate.
Separate.
We use levoflox and bread.
Okay. Okay, do you have any other questions?
Jay,
Dr.
Jay, Dr. Banson.
Dr. Vance.
Hi, Bea.
Hi, Doc.
So I'm so proud listening to you after now you're the one lecturing to everyone. So we're proud at how you started. We saw that, and we're happy for you now. Anyway, your lecture was so interesting because it gives the practical aspects of for the residents on managing pediatric cataract, especially the post-operative period, the complications. No, the easier part in pediatric cataracts is doing the surgery. The harder part is the visual rehabilitation. Okay, so these patients will be with you all throughout their lives, and you have to be following them up. And one of the complications you mentioned was glaucoma. Okay, and I've seen through my practice of how many years already, almost I have a high. I don't know if Mitzi will agree that at least 34% of the pediatric cataracts that I did, eventually after 10, 15 or 20 years or 10 to 15 years, they develop glaucoma, whether their surgery was perfect or not. It's something to do with probably anatomical changes. No? So how do that's why, you really have to follow up this patient. So what's from your experience, kasi sigurado yan eh. After 10 years, I tell them, oy, regular na kayo mag-follow up kasi baka mag-glaucoma. And I've seen that in the patients that I've done, whether with IOLs or without IOLs. What's your experience on the complication of pediatric glaucomas?
Actually, Doc, so far, I haven't encountered any case that developed secondary glaucoma. We encountered endophthalmitis, Doc, but not secondary glaucoma.
Wala pang 10 years yung practice mo kasi. So you will see it later on. Okay? That's, I think, a point that I want to stress to the residents that it doesn't end on surgery. Even after 10 years, they will develop the glaucoma there. So anyway, I hope the residents picked up a lot of the points that you mentioned. I know. I think whether you put biometry is really difficult, no? But you need to do if the patient can tolerate it, it's better to do a biometry than just approximating the post-op refraction. So you can get eggshell length and the keratometry readings, it's better. And we really target a little plus, a little depending on the age of the patient when you do it. But again, but in that case, another question, you did bilateral implant in under general anesthesia for that case?
Yes, Doc.
Okay. Well, kasi if you're going to do an implant in a child, I normally just do it one eye at a time because of the the complications of endophthalmitis. If you do bilateral, I don't know how safe it is, although I can do bilateral lensectomy in one sitting without implant. Okay, that's what we do now, and now I realize just to also usually for bilateral cataracts you do lensectomy when they're below 1 year of age, and then later on I noticed that it's better to put the implants at a later age. You just slide it inside on maybe on the sulcus na, because if you have a very good capsular rhexis, pwede mo ilagay sa sulcus yan. Hindi na in the bag. Kung nag-vitrectomy ka na at nag-posterior capsulotomy, mahirap na ilagay sa bag yan later on. Nag-fuse na yung capsular, yung bag na yan. So, usually sulcus na yan. And I've done a lot of these patients already, those who I operated when they were young, at 1 year and below. And then now I'm putting a secondary implant, and they do well. I mean, it avoids the complications of IOL in a small child na pinipilit mong ilagay yung adult IOL. Wala pa tayong pediatric IOLs kasi available. So really, that's what I notice is the better one now, except if it's unilateral. Unilateral is really the best. You have to put an implant, whether you like it or not, or contact lens. Kasi they will be amblyopic no matter what. They will always prefer the good eye. Anyway, thank you so much. I'm so happy with listening to your lecture, and I'm proud of you.
Yeah, thank
Okay,
you, Doc.
Bea. Okay.
Thank you, Doc.
Dr. Mitzi,
Pwede magtanong pa, Bea. Sorry ha. Ano lang, question lang. Kasi in GLAW, for mga GLAW patients na less than 2 years, sorry, that's you. We usually check the axial length of
Dr.
patients.
Mitzi.
Oh, yeah. Can you hear me? Sorry. I have a question lang with regard to, because you mentioned that you expect increase in myopia in your patients. In our GLAW patients, less than 2, we also monitor the axial length. Kasi if the axial length increases, then most probably may GLAW yung bata. Now, how for your patients na older than 2 years old, have you ever noticed is there a rate or a difference in the rate of the increase in axial length for most patients who have just undergone cataract surgery and those who have gone cataract with glaucoma and developed glaucoma? Will the rate of their increase in axial length differ or be more rapid? I'm just curious if you have noticed any of those things in your patients now older than 2 years old.
Doc, I haven't encountered patients yet that developed glaucoma post-operatively. I guess because my stint has only been a short while, and usually the glaucoma can develop much later on. And myopia development also doesn't occur like within a few months' time. Usually it develops over a longer period of time, and I haven't developed patients that long yet.
Wala.
Yes, Doc,
Thanks.
parang up to mga 1 year pa lang. But
Okay.
it's expected, Doc, kasi there's a natural myopic shift already for kids as they grow. And then, yeah, like what the research stated was pseudophakic eyes have an even higher myopic increase in comparison to patients with phakic lenses. So we expect in the long run, there's a greater risk nga overall. Well, articles which say that there's a 30% chance of developing secondary glaucoma among pseudophakic patients.
Thanks, Bea.
Do we have any other questions? I think siguro na yung last question.
Yes.
Pagpahingayin na natin si Bea. Dr.
Pwedeng
Chidora.
one more.
One more, Dr. Chidora.
Hi, Bea.
Hi, Doc.
I'm so happy to be listening to you and your good report. And I'm actually wondering about any case studies or reports on ICL over pseudophakic children
Okay.
eventually.
I haven't encountered, Doc, but I'll look into that. I'll look into that. In our training, we haven't actually even parang touched on that. In fact, there were a few cases where I wanted to try to insert our artisan IOLs, but we never really pushed through with those.
Yeah,
those cases.
it's
So,
something that's relatively
new.
new in the
Yes.
Philippine population, but then ICLs are implanted nowadays, and we encounter patients who have high errors of refraction or anisometropia. And I was wondering about the future of possible ICL implantation over your implant already in pseudophakic patients.
I'll look
Thank
into
you
that.
very much.
Thank you, Doc.
Okay, so I think that's our last question. So do we have any announcement from our RTO chairman?
Wala naman. So
Caballero.
it's the induction ceremonies of ano tawag dito, si Diggs and Nav on Sunday. Kaya lang it's really limited invitations lang yun. We also have a cataract mission this Sunday with some of our consultants helping out our residents. If you want to come in and say hi to them, please do so in the OR. Rem, anything else? Okay, thank you everyone and have a great weekend. Salamat.